Good morning, everyone. Today we are going to discuss one of the table in FRCS Urology Viva. So as you know, there are 8 stations, and when you go to each station for this particular table, the combination could be CA prostate, penile cancer, or testicular cancer. So what happens is at the start of the bell, the discussion will be, for example, starting on CA prostate. When the bell rings at 10 minutes, the discussion stops and it suddenly changes into, for example, testicular cancer, and then the discussion will go on for 10 minutes time, and at the end of that 10 minutes, that table is completed. So even though we say that it is 10-minute sessions, in fact it is like 20 minutes. So you will be continuously speaking for 20 minutes in one station. So we will try to have that feel today. So we will discuss the table of CA prostate and either testicular cancer or penile cancer. There are instances when it all went through either penile cancer or testicular cancer without discussion on CA prostate. So that's also possible. So we will start now. Your time starts now. You are on the CA prostate testicular table, testicular cancer table. Okay, so you received a 2-week wait referral from your GP for a 26-year-old gentleman who presented to GP with a abnormal feel on the left testis. The GP arranged for a urgent ultrasound scan which shows a hypoechoic mass on the left testis confined to the left testis. The right testis is normal in ultrasound scan. How do you want to proceed with this information?
So I'd want to ensure that this patient is triaged into a urgent 2-week wait clinic where I will assess them personally with a urology cancer nurse specialist present. I'll see the patient and confirm the side of the whether he has any palpable masses or swellings, whether any overlying skin changes, and whether he has any systemic symptoms, including shortness of breath and hemoptysis, and if he's got any other symptoms in the testis. I'll establish his past medical and surgical history, including a past history of testicular cancer and undescended testes requiring orchidectomy. I'll ask about a family history of testicular cancer, and I'll ask the patient if he has any children and desires further extension of his family if he has any. I'll then perform a chaperone physical examination, performing a general examination first in the supraclavicular, thoracic and abdominal regions to look for signs of metastatic disease. I'll examine the inguinal regions for any previous surgical scars, and I'll examine the testes for the presence of any palpable masses, looking to note their presence, location, the size, whether they're fixed, and the presence of any tenderness.
Well done. So, what are you going to tell the patient?
With the urology cancer nurse specialist present, I informed the patients of the ultrasound findings and that they are highly suspicious of a new left testicular cancer and that he needs urgent further management and investigation. I'll arrange for further investigations in the form of serum tumour markers, which will be a beta-HCG, alpha-fetoprotein, and lactate dehydrogenase. I'll request a contrast-enhanced staging CT scan of the thorax, abdomen, and pelvis. But more importantly, I will counsel the patient about undergoing an left radical inguinal orchidectomy as soon as possible on the next available elective operating list. And this will be with the offering of preoperative sperm banking and testicular prosthesis insertion at the same time.
Okay, so he agrees to that, and he's a bit worried. He hasn't completed his family. Regarding, do you give him any other options apart from giving the option of radical left inguinal orchidectomy?
So I'll explain to him that the alternative options could be surveillance, and
Sorry,
although this would
I'm
we're
sorry.
treating this as a cancer until proven otherwise. Sperm banking is available to him, and again, I'll offer that to him. And then, depending on the size of the lesion, he could be offered a partial orchidectomy. However, this is not recommend for this particular situation. It's not recommended within the EAU guidelines.
Okay. So he's concerned that even he hasn't started a family yet. He's concerned regarding the cosmetic outcome after the procedure. He's asking whether he has read about the processes. He's asking whether a processes can be inserted at the same time. What will be your option on that?
I will inform him that prosthesis can be inserted at the same time, although there is a risk that because it's a foreign body, if he requires adjuvant chemotherapy, that it poses an infection and sepsis risk. However, the studies looking at this have not demonstrated any significant increase in sepsis with testicular prosthesis. In terms of the cosmetic appearances, I would counsel him with the aid of a patient information leaflet, and I'll also inform him about the potential risks of prosthesis insertion.
Brilliant. So he agrees to that. He underwent sperm cryopreservation. Are there any investigations, any blood investigations specifically you do before sperm cryopreservation?
This would be viral serology, screening for HIV, hepatitis B, and hepatitis C.
Brilliant. And his serum tumor markers came back as normal. How does that help, the serum tumor markers pre-orchidectomy?
Pre-orchidectomy, they have a role in diagnosis, in staging as well, because there is a separate S classification to the TNM staging. So pre-orchidectomy, they have a role in diagnosis and staging.
Okay, so for the S classification, so will you do serum tumor markers after orchidectomy?
Yes, I'll repeat them at 7 days post-op to ensure that to see if these have fully resolved and within the normal levels.
Brilliant. And what is the reason that we are doing it post-orchidectomy?
Post-procedure, it is if the serum tumor markers remain persistently elevated, where they're elevated before, it could be a sign of subclinical metastatic disease or the presence of germ cell tumor in the contralateral testis. And then in terms of further times post-orchidectomy, it's used to monitor response to further treatments, but also for evidence of disease relapse.
Okay, well done. And what is the chance that his fertility will be gone, or he will become subfertile if he needs a chemotherapy?
So during the period of chemotherapy, he will be subfertile. However, patients' fertility is usually recovered 1 to 4 years after chemotherapy.
Okay. And then, so he had his radical orchidectomy. The specimen is the case is being discussed in the MDT post-orchidectomy. The pathologist says that it is seminoma histology. What other information do you want apart from the histology of seminoma?
Given that this is a seminoma, I want to know the size of the tumour, whether it's more than 4 centimetres, and if there's any reti testis invasion, because these are risk factors for relapse. And in terms of other information, I want to know whether the tumour, I want to know the T staging, so whether it's involved the tunica albuginea or tunica vaginalis, if there's evidence of vascular invasion, if it's invading the spermatic cord or extending through the whole specimen. I want to know if there's any evidence of GC-NIS as well.
Okay, Well done. So this is a 2 centimeter tumor confined within the testis, no invasion of the rete testis, and then there's no invasion of the spermatic cord as well. The CT thorax, abdomen, and pelvis shows that there is no clinically significant or radiologically significant lymph nodes in the retroperitoneum or any signs of mets into the chest. What is the staging system now?
So for this patient, it would be a PT1 N0, M0, S0.
Well done. And how are you? Does he need any more treatment, or can we just observe him?
So I discussed this case at the Urology SMDT. He's got a clinical stage 1 seminoma, and further management options would include either surveillance or a single cycle of carboplatin chemotherapy. Radiotherapy to the retroperitoneum is available as well, although it is not recommended as one of the first-line treatments.
Okay. If he agrees for adjuvant chemotherapy, which chemotherapy will he give?
Given that he's got a clinical stage 1 seminoma, the option would be carboplatin.
Okay. And okay, so we'll stop there. We'll go through the next scenario. So in this one, you are referred a 62-year-old gentleman by GP who had an abnormal DRE. The DRE shows that there's an abnormal area on the left lobe of the prostate. His PSA is elevated at 6.8. The repeat PSA is again 6.9. How would you like to proceed?
So when I see this referral, I'll triage it again to be seen in an urgent 2-week clinic, where I'll see the patient myself with a urology cancer nurse specialist present, and I'll first take a focused history. I'll ask the patient about any specific symptoms, including voiding LUTs, visible hematuria, erectile dysfunction, back pain, and any systemic symptoms. And I'll ask them if they know about the DRE findings. I'll establish their past medical and urological history, establishing their general fitness for treatment. I'll ask about a family history of prostate cancer, and then I'll perform a chaperone physical examination. I'll note the ethnic makeup of the patient. I'll look to elicit any abdominal or loin tenderness. I'll examine the external genitalia, and I will perform digital rectal examination to determine the prostate size, consistency, and the presence of and location of any irregularity or nodularity.
And so it confirms that there is a abnormal area on the left side, no other risk factors, no family history of any significance, no lower urinary tract symptoms. He requested the PSA to be checked because his friends had his checked and was positive. So how are you going to proceed from here?
I'll counsel this patient about the DRE findings and also the elevated PSA, and that with a combination of these, there is a suspicion of underlying prostate cancer. Given that the PSA has remained elevated on a repeat, I will counsel the patient about undergoing biopsy of the prostate with a preceding multiparametric MRI scan to look for any targetable lesions.
Okay, so he had his MRI scan, which shows a Peyer's 4 lesion in the left peripheral zone, corresponding to the clinical finding. So, how do you? What other things that you want to see in the MRI scan?
The other information I want to know is the prostate size in cc's, because this will help me to also calculate PSA density. I want to know about any lesions within the transitional zone, and whether there is any potential evidence of extracapsular extension of the lesion, and also information, the appearance of tissues around the prostate, extraprostatic tissue, as a form of local staging.
Brilliant. So it shows that it's a Parad-4 lesion, left peripheral zone, prostate volume 40 cc, which gives a PSA density of 0.13 with a T2 N0 M0, no extracapsular extension. What all features in the MRI scan shows that it is suspicious for prostate cancer, a lesion?
So the multiparametric MRI scan consists of a number of different sequences, which are diffusion weighted imaging, the apparent diffusion coefficient, and T2 weighted images. The DWI and ADC are more specific for the peripheral zone, and T2 images for the transitional zone. And on DWI and ADC, one's looking for restricted diffusion. So on DWI, any lesions would appear bright, and on ADC it will be darker, whereas on T2 weighted images, one's looking for a loss or reduction in T2 signal.
Well done. What is biparametric MRI scan?
Biparametric consists only of two sequences, but I can't recall which ones they are.
Okay. And what is the evidence that a pre-biopsy MRI scan can improve the outcome of biopsies?
This comes from the Precision trial, which randomized men with suspected prostate cancer to either multiparametric MRI followed by targeted biopsy alone, or systematic trust biopsies. And this found that the intervention arm detected significantly more clinically significant prostate cancers at 38 compared to 26%, and also that significantly fewer clinically insignificant cancers were detected at 9 compared to 22%.
Okay. So he agreed to undergo the local anesthetic transperineal biopsy. Is there any protocol that you follow while doing the local anesthetic transperineal biopsy?
There is the Ginsberg protocol, which divides the prostate into different zones, which are going from the apex, the middle zone, and the base, and recommends a total of at least 4 cores from each of these zones, aiming mostly for the peripheral.
Brilliant. So he had his prostate biopsy done. His case is being discussed in the MDT. So the histopathology shows that there are 24 plus 4 cores, and 4 out of 28 cores were positive for Gleason 3 plus 3, which gives a Gleason grade group of 1 with less than 50% core involvement. What is grade grouping?
So grade grouping is also another term for the International Society of Urological Pathology grading system for prostate cancer, and it splits the different Gleason grades into different separate categories based on the biochemical recurrence-free probability survival at 5 years. So a grade group or ISAB grade 1 is any Gleason 6, grade group 2 is Gleason 3 plus 4, grade group 3 is Gleason 4 plus 3, grade group 4 is any Gleason 8, and a grade group 5 is any Gleason 9 or 10 score.
Okay. What do you think the MDT decision will be for this patient?
So looking at he's got a grade group 1, and according to the NICE classification, based on his PSA, clinical staging, and the Gleason score, he's got a low risk tumour. Therefore, it is likely they'll recommend active surveillance.
Okay. And how are you going to counsel the patient on this decision?
So I'll see the patient again urgently with one of my urology cancer nurse specialists present. I'll explain that while the biopsies have proven the presence of a prostate cancer, it is in the low risk category, and is a cancer which therefore may not need any treatment and can be managed with close surveillance with swift action to be taken should there be any changes in the PSA or DRE findings. I'll inform him that we'll follow active surveillance protocol, which will consist of PSA every 3 months, measuring of PSA kinetics, and DRE at 12 months and a multiparametric MRI at 12 to 18 months, and that if there are any concerns about the DRE findings of PSA, then he'll have a repeat multiparametric MRI, possibly followed by repeat biopsies.
All right. So what's the evidence for active surveillance?
Sorry, can you repeat that? You broke up.
Sorry. What is the evidence for active surveillance in Gleason 3+3?
So the main evidence at the moment comes from the Protect trial, where men with localized prostate cancer are randomized to either active surveillance, radical prostatectomy, or radical radiotherapy. In the active surveillance arm, the overall survival at 10 years was 98%. However, there was over the 10-year follow-up period, there was a 21% chance of progression of disease in the active surveillance arm, and also an 8% chance of metastatic disease, and 53% of patients required radical treatment.
Okay, well done. So you are following this patient, and at year 1, his PSA is remaining stable, and his DRE is again remaining stable. There is abnormal area but not progressed. Okay, we'll stop there. Okay, so we'll go. Are you all right for the feedback now?
Yes, please.
Brilliant. So, how do you think it will?
Yeah, I think those two progressed through them. I think it didn't get to the very end of the very last questions, but I'm presuming that's not going to be a problem, really.
Because in this scenario,
I don't want to rush things when I'm answering.
Yeah, brilliant. So yeah, I think that's right, because in this scenario we can know that mostly it is going through the active surveillance pathway. So sorry, we'll start one by one. About the testicular cancer, the good thing about that is you initially involve the CNS in the discussion, because we know that this is a scenario, we know that there is a tumor which is already confirmed with the ultrasound scan. So it should, even the first consultation would be like in a Breaking Bad news situation. I mean, it is a situation where we have to act fast and arrange for a radical orchidectomy in the next available list. But it's always better to bring the MDT in the discussion. So you can say that if there is an MDT available in between, I will definitely arrange for the MDT, but otherwise, but won't wait for the MDT to happen before going for the radical orchidectomy. If examiner asks, do you want to proceed without any further investigation, you can say that I can always have a discussion with the radiologist. So things like, but it's always better to bring the MDT. If most of the time there will be an MDT happening before the planned procedure. Yeah. And also we have to give time for the sperm banking, isn't it? So we have to have some time before rushing before the orchidectomy, because he's only 26. He definitely needs sperm banking. And regarding the counseling, I always take it like when the person comes with a lesion which needs the orchidectomy, there are always 3 things that we have to address. It's not the removing of the testis alone, but one is the sperm cryopreservation and the discussion on prosthesis. Even the Bow's information leaflet is designed like that. So it is removal of testis plus or minus prosthesis insertion. So even if you give a Bow's information leaflet to a patient, we have to address the question of what we are going to discuss regarding the prosthesis. So we can bring those 3 points always, especially when the patient is young and hasn't completed the family, and because these persons will be very concerned about the cosmetic outcome. And with the Manchester group paper, Robinson et al. And Prof. Clark, we know that out of the 276 that they inserted, only 1 needs to be removed. So chance of
Yeah.
anything abnormal going after a testicular process insertion is very, very low.
Yeah.
But you brought all those things really nice, and I had to prompt on that sperm banking and the process thing. That's only so. Whenever you discuss on the radical removal of the testes, always think about the other two options as well. So it's like a package. Brilliant, and no concern about other things. It went well with the discussion part.
Okay.
And,
what would have been the further question at the end before the time ran out?
Yeah, my plan was to take you through the seminoma relapse and up to the FDG PET.
Okay.
And follow up. That was the end of that scenario. But you were almost there, more than 90%.
Okay.
One thing is that I had to mention that regarding the tumor markers AFP, LDH, beta HCG, the post-orchidectomy tumor markers is used for staging.
Okay.
So we stage it only once, the S stage only once, and that is done once the tumor markers stabilize.
Okay, so that's done only post-op.
Post-op, yeah, it's post-orchidectomy. Okay. So there is a I mean, the EU guidelines also confirms that. So it's always we stage it only once. The staging is only once. Even if it relapses later, the tumor markers goes up. Doesn't matter. Staging is done only once, and that is post-orchidectomy. Once the tumor markers stabilize, according to the
pre-orchidectomy is just for diagnosis.
Exactly, and diagnosis, and also sometimes the histology will show seminoma, but the AFP will be elevated. In that case, we have to take clinically it is non-seminoma, even though histology shows seminoma. So that is the importance of doing tumor markers before before orchidectomy.
Yeah.
So before orchidectomy, it's mainly for possibly mainly diagnostic, because if AFP is elevated, it is not pure seminoma. Then also it might help to see if the tumor markers are coming down. It might say that it is confirmed. I mean, there's not much of prognostic value, but it is a good sign. It's the only thing that we can say. But staging is based on post-orchidectomy tumor markers. I think that's the feedback on that part. And regarding the prostate, how do you, what are the good things that you feel about the prostate cancer?
Yeah, I think I was pretty decisive in terms of my management. Exactly. Took into consideration all the clinical and biochemical findings. MRI, in terms of the information I wanted, I got that. I think it's just those questions in terms of the biparametric MRI, and then there was one other question I had as well, but I can't remember what it was now.
So I've written 3 things here. So one, so regarding the things to improve, or I mean, this was a really good session, but still a couple of things to improve are biparametric MRI, because as we know, we are moving away from the contrast enhancement now, because for the PIRAD staging, the contrast enhancement is not much of importance. Contrast enhancement helps us when there is suspicion of prostatitis, post-biopsy MRI scan, which never happens now, because it's always streamlined into the pathway where the MRI scan happens before the biopsy. So the role of dynamic contrast enhancement is coming down. So that's why in almost all UK hospitals, we are going more towards biparametric MRI. So there is only the T2 weighted. Mainly.
So biparametric does not involve contrast enhancement.
Exactly. So there is no need for contrast. The good thing about not having a contrast is the MRI scan can be done by the technician without the presence of a doctor.
Yeah.
Because there is no reaction or anything that can happen. And that fits in well with the 2-week wait pathway.
Yeah.
Sometimes if needed, then they can always go for a dynamic contrast enhancement MRI scan afterwards. Only that phase.
Yeah. Can I just ask, with the contrast enhancement, the gadolinium, is that looking in the T2 weighted images?
Exactly. And also it is mainly to see I mean, if there is any confusion regarding the parad scoring, especially as I mentioned before, if there is prostatitis, then it might be difficult to assign a parad scoring. And also, if there is any previous history of biopsy with a hemorrhage in the prostate, it is in these scenarios that we use the contrast enhancement. There is an article in European Urology. There are two parts in that one. What urologists should know about MPMRI, part 1 and part 2. And part 2 paper, it is. I think I'll upload that in our group today.
Yeah.
It is an. I mean, you nicely said about it. T2 for the transition and the other things for the peripheral zone. So I will upload that one.
Yeah.
It is a nice paper to read regarding the MRI, and it is mainly for the urologist. And regarding the active surveillance, it's always nice to bring the BOWS information leaflet on active surveillance.
Oh, yeah.
Because
It's been mentioned before.
Exactly.
Yeah.
And regarding the active surveillance, PROTECT trial is fine, but as you know, the PROTECT trial was mainly active monitoring. So it was not adhering to the strict definition of active surveillance. So it is still a bit confusion when we say PROTECT trial, because when you go through the details of PROTECT trial, we can say that it says that active monitoring, not active surveillance.
Okay.
It is slightly different from the active surveillance protocol what we follow now. So clot study, the Canadian study would be an ideal, because we now have the 15 years follow-up. So I have put that slide in the discussion. So when you go through the video, you can I have put a summary of the slide.
Broad.
The clots trial. I mean clots active surveillance follow-up.
Broad. Okay.
And yeah, you nicely all the numbers were excellent and correct regarding the precision trial. I would suggest to bring the promise trial as well, because that was the initial one that.
Things because he talked about targeted biopsies. I think precision is more specific for that.
Precision is more specific. Yeah, that's true. And we have now the new trial, isn't it? The PRECISE trial from Canada in 2021. So
is that being published?
It's been published, and it goes in along with the precision trial. Almost similar findings. I put that in the slide as well. So I will keep that slide at the end so that you can the PRECISE trial. So it was published in February 2021. Same thing, MRI versus standard evaluation phase 3 trial. Precision was 500 subjects. This was 453, almost similar. So this is the time when we can see that those results were reproducible in the subsequent trials. So it confirms that the pre-MRI, pre-biopsy MRI is going to stay.
Yeah.
And also, it is but when you see the patient in the clinic, we can say that we will try to see the patient with a pre-arranged MRI scan. So when the GP referral happens with the PSA result and the abnormal DRE, before we see the patient, we can try to arrange for an MRI scan before we see the patient in the clinic, so that we can have a meaningful discussion of what's going to happen, isn't it? Otherwise, when we see the patient, we have to say that we will do an MRI scan, and then we have to see you back again after the MRI scan result. So some of the hospitals has even moved through, because previously we were doing it as a one-stop clinic. So the patient with abnormal PSA being referred by GP, having the trust biopsy on the same day.
Yeah.
So we are moving more towards in that lines now. So what happens is the diagnostic pathway is being changed now, where the GP referral happens. As soon as we get the GP referral, if it is appropriate, we will arrange for a MRI scan on the morning of the clinic. So the patient will have the MRI scan, will be reported on the same before afternoon, and the patient comes for the clinic in the afternoon, discussion and counseling. And if the patient agrees that he can undergo a local anesthetic transperineal biopsy, that will happen on the same day in the outpatients. So that's the progress that we are trying to make. So we don't have to go through that you don't have to explain that, but still it's better to explain that I will try to arrange an MRI scan before the clinic appointment, and try to get it reported. So, but I mean, it was a good discussion, no concerns. But I'm saying these small points where we can just push through.
Yeah. So with the because again, in terms of exam, what would they be comfortable with me saying I'd see the referral, I'd try and arrange a prior MRI scan, and if you do that, would you then kind of call and contact the patient? Because that's what I'd probably prefer to do.
Exactly. So in our hospital, it's like when we receive the GP letter, we will arrange an MRI scan prior.
Okay.
So when we see the patient,
that's routine for you now.
Yeah, even on a Thursday afternoon, we have this LATP biopsy session where we see the patient and then we'll counsel. Some of the patients will not agree to straight go ahead with the biopsy. We can understand that. So in which case we will give the information leaflet and everything. We'll give them enough time. But some persons are really concerned about and they will agree with the TP biopsy.
Yeah, okay.
But again, we have just started only. We are in that initial audit and governance phase.
Yeah, okay.
Brilliant. I hope this was helpful.
No, they always are.
Thank you. Great. And so the most important. So this is how it is going to happen. Okay, it's 20 minutes.
Yeah.
So 10 minutes and 10 minutes straight. And you need to have that 100% energy from starting of that 20 minute session to the end of that, and you have to switch on to the other session very quickly.
Yeah.
So I hope
exactly
you got that feel, isn't it?
Yeah. No, I think if the format is like this for the remaining sessions, then that's what we need.
Yeah, definitely. So we have to plan it like that because. We have only 3. I mean, we have 3 weeks. Not only we have 3 weeks, definitely. That's good.
Yeah.
And it's mainly these 3 weeks will be mainly to, going to that high level to sharpen the answers, things like that. There's no concern about the knowledge or anything, but it's to give it in a very precise manner.
Yeah.
Thank you. So
right.
We will arrange for the next session, and then I'll update you.
Yep, and then I'll see you tomorrow in Stoke.
Oh, that's brilliant, yeah. Great. Thank you so much. And study well.
Yeah, have a good, enjoy the rest of your weekend, Anish.
Thank you. Thanks so much. Bye-bye.
Bye-bye.